Today, we are sponsored by Provider Solutions and Development, a community of experts dedicated to offering holistic career coaching to physicians and clinicians throughout the entire job search. Start the conversation today at psdrecruit.com/Curbsiders.
The Curbsiders have partnered with VCU Health Continuing Education to offer free continuing education credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org to create your free account and to start claiming CE credit.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Well, Paul, Stuart, it was another great one.
Well, hi, Matt.
We just talked.
Are we starting?
We are starting, Stuart, which is why you're interrupting me. So we talked about breast cancer screening tonight. We also talked about how to work up the breast lump. And we had a fantastic guest and a fantastic producer who we'll introduce in a moment here. But Paul, first, can you remind people, what do we do on this show?
Such a great question. We are the Internal Medicine Podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. And our amazing producer brought us an amazing guest to bring us amazing clinical pearls. So we had the good fortune to have Dr. Nora Ploutz at Taranto with us, who brings us our guest today. And I'm going to let Dr. Taranto tell us all about who we talked to and what we talked about.
Hey all, I'm so excited about this episode. We just had a fantastic conversation with our guest, Dr. Nancy Keating. She is a general internist at Brigham and Women's Hospital, as well as a researcher in the Department of Healthcare Policy at Harvard Medical School, not to mention one of the fabulous Wednesday Phyllis Gen Center preceptors, where my primary care clinic is. Her research examines provider, patient, and health system factors that influence the delivery of high-quality care for individuals at risk for or diagnosed with cancer. She's authored a number of reviews and research studies examining breast cancer screening and is quite enthusiastic about helping women make informed and shared decisions about screening. She's taught us about all of this and more. So without further ado, let's get to it.
Hey, Nora. What did one mammary gland say to the other mammary gland?
Oh
no.
Boy.
Let's not.
Oh, no.
Let's not.
I gotta ask what?
Thanks for staying abreast with me.
I think we can actually keep that in the show, Paul.
That could have been far worse. Yeah. All right.
I was
We'll call it a
prepared.
win.
Pretty good.
You know what would be really funny? If someone could take the Black Eyed Peas song,
no.
My Humps, and actually turn it to like My Lumps, and talk about breast cancer screening with it.
Yeah. I feel like I've actually thought about that in my head also.
What is happening? I don't like it.
I'm not sure what that says about us. Yeah.
Claire,
I don't know,
please
Nora.
put this somewhere in the show. Maybe at the end. Nancy, thank you so much for joining us. I know we got postponed a little bit, but I know this is going to be worth the wait. Before we get into talking about breast cancer screening and breast lumps, can you tell the audience, give them a one-liner about yourself, and maybe throw in a hobby, something interesting you do outside the world of medicine?
Great. So I'm a physician scientist with a primary care practice, and I'm a health policy researcher where I study organization, delivery, and payment of healthcare for individuals with cancer or at risk for cancer. I'm married. I have 2 kids, ages 12 and 13, and I would say probably my most favorite hobbies are travel and cooking.
What have you been doing for travel in the last few months?
So the COVID era has created some challenges. We've had to switch plans on 2 international trips, but I did just get back from 2 weeks a week in Maine and a week in Vermont. And in many ways, COVID provided a nice opportunity to do some more exploring in areas that are pretty nearby, and I clearly haven't spent enough time in. It was really great.
Like seeking out the biggest ball of yarn and
Sure.
roadside attractions, things like that.
That famous main attraction, the ball of twine.
Well, we spent almost a week in Acadia National Park,
Oh my
which
gosh.
is one of the parks I've never been to. I've been to about 30 of the U.S. national parks and somehow haven't been to the nearest one to me. And it really was spectacular.
Yeah. My family has a cottage in Fly Point, Maine, near Blue Hills. So not too far from Acadia.
Great.
And I should mention to the audience, they may be hearing Stuart's cat. And Stuart, what was the cat's name again?
Pablo Picasso. I can definitely hear him.
Yeah, we could probably get the cat out of the room, but let's just record with Pablo
he's out of the
tonight.
room. That's the problem.
He seems like a great cat. Did you want to ask Nancy any questions in between the meowing of your cat?
Yeah, absolutely. So, Nancy, what's the best advice that you could give to our up-and-coming young, especially female physicians, in order to reach the level of expertise and accomplishments that you've done?
I think that probably the most important thing is to figure out what you love to do and find a way to do it and work hard and be committed. And I find with those things, good things tend to happen. Nora did ask me to comment specifically on one piece of advice that has been meaningful for me from women in medicine. And I'm going to date myself a little bit and refer back to a paper that was published when I was in my training in the Annals of Internal Medicine by Molly Carnes. And she was writing about balancing work and family. And she used this really wonderful analogy that I still remember. She was kind of talking about how to simplify her life and make things close together. And she gave this analogy of a street performer who has 10 plates that he's spinning on little sticks. And she talked about how, if he keeps those sticks close, you just give it a little tap and it keeps spinning. But when they get too far away and you can't spin them, they sort of wobble and fall off and break. And whenever I'm thinking about something new that I'm doing or where I'm going to live or where my kid's pediatrician should be or where, how I'm going to co-locate school and work and home, I really do think about this idea of getting all these plates spinning really close to me. And I feel like that's just been a really nice image to have over the years. I can get you that paper if you want to link to it.
Sure. I think there's someone that spins plates at Quincy Market. If at least there was like many years ago when I used to live in Boston. We also like
a metaphor, Matt.
Was it, Paul? I don't think you know what a metaphor is. Nancy, how about a book recommendation?
Yeah. So, I love to read. And in thinking about books that other physicians might enjoy, something I've read in the last 6 months or so was Evicted by the sociologist Matthew Desmond. And while this isn't specifically about healthcare, it provides a really compelling description of the challenges that so many of our patients and so many Americans are facing in just being adequately housed. And I think that the more we think about the impact of social determinants on the health of our patient population, it's just, I think, a really wonderful insight. Matthew Desmond spent a year embedded in 2 different communities in Milwaukee, and the stories he tells are just incredibly compelling.
Great recommendation. Thank you. Nora, did you want to give a pick of the week before we get on with the show?
Sure. I have one in mind. This is actually another medical podcast. I'm not sure that y'all have heard about it. It's called Run the List. It was started actually by a co-resident of mine, one of my first residents when I was an intern, who is a wonderful medical educator, one of the most compassionate guys I've worked with, Walker Red. And the podcast has been growing since then. It's shorter takes on a lot of different kind of key medical complaints and how to work them up, kind of frameworks that are really good and a little bit briefer than our conversation. So highly recommend.
Hey, is a career change part of your strategy for the future? Well, our sponsor, Provider Solutions and Development, has a team of experts ready to guide you through today's physician job landscape. With over 20 years of experience, they are committed to finding you the right team, the perfect setting, and the work you are meant to do. PS&D's in-house recruiters are not focused on quotas, and they do not work on commission. Whether this is your moment to shine, pivot directions, or discover something new, Provider Solutions and Development has access to hundreds of opportunities across the country. So reach out today at psdrecruit.com/Curbsiders. So with that, unless Stuart or Paul have any really pressing picks of the week, we can get on with the case. Nora, do you want to do the honors?
Yeah, of course. So for our first part of the case, we've got Miss Brenda Cantwell. She's 46, and she has a history of hypertension, major depressive disorder in remission, and obesity, who presents to your office in the outpatient setting with a right-sided breast lump. She states it's not painful to the touch and that her husband actually noticed it a month ago. It hasn't dramatically changed in size since she noticed it, and hasn't noticed any nipple discharge, any changes to the skin, no pain. Otherwise, really no symptoms. And so kind of starting with this case, I'm wondering what things on that history are you looking for, and what other questions are important to ask in gathering more data on this person with a new breast lump.
Great. So you've already told me that it hasn't changed much, but it does seem to be new over the last month or so. It's non-tender. I would be curious if she's ever had lumps in her breast before, if it's associated with her periods or her menstrual cycle, if she's had any breast trauma, if she has any history of cancers in her family, particularly breast cancer, but other cancers that might be associated with breast cancer, including ovarian cancer, endometrial cancer, colorectal cancer. If she's had a recent pregnancy, obviously that would be relevant. And thinking a little bit about other risk factors for breast cancer. She is in her 40s, a point at which risk for breast cancer starts to increase in prevalence. And so with a painless lump, obviously, thinking about malignancy is a key thing to pull out.
How do you think about the differential diagnosis for this? Like if you're in the primary care clinic, you're seeing someone with a lump, how do you think about it? Does it differ based on the patient's age? Can you talk us through that?
Yeah. So, the thing that we obviously are most concerned about is ruling out cancer. In these lumps, cancer is actually a pretty uncommon diagnosis, probably 10% or fewer, depending on someone's age. But it's the thing that's most important to find. And so I'm always thinking about that. Aside from that, things like breast cysts are very common. Fibroadenoma are very common. Just nodular fibrous breast can be something that can sometimes feel like a lump, although that tends to be a little bit more bilateral. There, are for more acute things, thinking about a breast abscess, particularly if there's fever or redness or swelling, in someone who's been recently breastfeeding or recent pregnancy can have galactocele. Trauma can be associated with fat necrosis, so someone gets hit in the breast with a softball or involved in a motor vehicle accident. And those are kind of the main things that we're thinking of. Obviously, the risk of malignancy, as I mentioned, goes up as you get older. For women who are quite young, that is incredibly uncommon, although it's not zero. So it should always be on our differential. But as we're thinking about evaluating them, this woman's 46. I certainly, and she has a painless mass that is new. I am going to make sure that it's not a malignancy.
So there's a lot of controversy that surrounds doing clinical breast examinations. And per this patient's reported history, her husband, I assume, was doing a clinical breast examination about a month ago and found this lump. And what's your take on doing these, just doing in general clinical breast examinations as part of a routine screening?
Yeah. And so, I'll sort of distinguish a couple of things. One is the breast self-exam and the other is the clinical breast exam, and also think about them both in the screening context and in a diagnostic context. Obviously, in this case, a clinical breast exam is highly indicated because she has a mass. So we're doing case finding. This would be a diagnostic clinical breast exam. But what do we know? Well, first, let's just mention breast self-exam. So for many, many years, we recommended that women learn how to examine their breasts systematically once a month. And that has actually been tested in 2 large randomized clinical trials, one in Russia, the other in China. And both trials found no benefit of decreased breast cancer mortality in this population that's not being screened, and actually an increase in the number of false positives and a cascade of diagnostic testing that didn't actually cause benefit. So now it's generally felt that recommending breast self-exam is not something that we need to be doing. That said, there still is a reasonable number of breast cancers that present clinically, and up to 10 or 15% of all breast cancers are not ever evident on mammography screening. And so I think that we have to recognize that some patients are going to be finding masses on their own, and we should be attuned to that. I think then the next question comes to, what about clinical breast exam? And clinical breast exam has not been shown in randomized clinical trials yet to lower breast cancer mortality, although there is a large study underway in India that we hope to have reports of in the next year or two that hopefully will help us to answer this question. For many, many years, this was recommended that at least once a year, women should have a clinical breast exam. In 2015, the American Cancer Society updated their breast cancer screening guidelines, and we'll talk about them a little bit later, but they actually explicitly recommended against routine clinical breast exam. The United States Preventive Services Task Force has instead said that the evidence is insufficient to recommend for or against it. And I know that this has led a lot of people not to do clinical breast exams. The American Cancer Society basically justified this decision by saying, we're worried that it will cause false positives and unnecessary biopsies, and there isn't enough evidence to support it. And they said, it takes time, and we'd rather you spend that time focused on engaging patients in shared decision-making about their screening decisions. But I will say, you could interpret the mammography data. Some of the trials used clinical breast exam in the control group, and other trials didn't. And you could actually look at the data and find some potential indirect evidence of benefit of clinical breast exam. So I actually still do it once a year in women. And I use that time while I'm doing it to often, talk with them a little bit about mammography. Sometimes I'll also do it while I'm doing their review of systems or whatever. So I still think that, we just can't disregard the fact that a lot of cancers are found not by mammography screening.
We're becoming notorious for finding out that we do exams completely wrong. So I'm wondering if you could talk us through your approach to the clinical breast exam, since I've gotten probably some dubious advice throughout the course of my medical training. So I'd love to hear how someone who actually does it well does it.
Yeah, well, and probably most of us don't do it well. And this was actually one of the other reasons the American Cancer Society said, let's not do it, because they felt like most people probably weren't doing it well enough. The official instructions are that we should first inspect, often first with the woman sitting, and then with her lying down and her arm over her arm behind her head. And we first inspect, look at the skin, make sure we don't see any dimpling, retraction, nipple inversion, redness, skin changes. And then in the most complete exam, we would actually examine sitting up and then again lying down. I will say, in all practicality, in most women, I just do it lying down, particularly for screening purposes. In this patient, I would try to do it both upright and lying down. And the key is to be sure you want to feel for axilla in the regional areas. So under the axilla, the supraclavicular area, the cervical nodes, and then you want to cover basically the whole rectangle that includes the breast tissue, which extends into the axilla. And there are different ways you can do it. There's the radial approach, where you kind of come out like the spokes of a bicycle wheel. There's the circumferential approach, where you start in the middle and you go in concentric circles around. And then there's what some people call the lawnmower approach, where you just kind of go back and forth. And as you're going through the breast, you should be using the base of your fingertips, not the tips, the pads. Thank you, Nora. And you should be pressing both first lightly, then medium, and then deeper. And you go kind of systematically through the breast, feeling for irregularities. And what you're looking for is a discrete mass. A lot of women have somewhat nodular breasts, but if it's generally nodular throughout, That's not typically concerning. That just is sort of irregular breast tissue, very common in younger women. But you're looking for actually a discrete mass that you can kind of feel around. And then when you're feeling it, you want to know, is it fixed, which is more concerning for cancer, or is it mobile and spongy? Is it tender? Tender nodules tend to be less likely to be cancer.
So I was trained by a breast cancer surgeon, and he always told me that the way that he initially inspects is to have them lean forward, internally rotate, and then have them let the breast kind of hang in front to look for irregularity. He's the only individual who ever actually taught me how to inspect like that. Is that something that's taught in the literature, or taught? It was just a unique way of inspecting for asymmetry.
Yeah, I've not actually been taught that, but it sounds like a great suggestion. And, certainly I think this is part of the reason for the upright posture is to really see that the breasts are hanging symmetrically. And I think that inverting of the shoulders could actually really enhance that a lot. So I like that suggestion.
Yeah, Stuart, I actually was taught that as well. Also only by a breast surgeon though. So it may be just part of their exam.
Yeah, I was trying to find his name. I was trying to find his name. It was his last name is Lister, but I can't find him.
Well, let's get back to Miss Cantwell. So she's 46, and we talked a little bit about some of the historical things that we would look for, risk factors that might make us think more malignancy, and then the differential. We talked about how to do the exam. So let's say we don't feel anything on exam. She's saying she found this lump, or I guess actually, Nora, you tell me, it doesn't say in our case here, were we able to feel it on our clinical breast exam or not?
Let's say we did feel it, and maybe we can quickly talk about how it would go if we didn't feel it.
Yeah, that sounds great. So, if we feel it, we definitely need to do something about it. I think that's sort of, rule number one. And what we do about that is going to depend a little bit on her age. If this is a young woman, particularly a woman under the age of 30, we typically start with a breast ultrasound. And the reason being that mammography is just not very sensitive in women who are young, who tend to have very, very fibrous breasts, and the imaging pictures just aren't that good. So we start with an ultrasound. We tell them exactly where we find the mass. I see a mass at 2:00 on the right breast. And then the ultrasound tech can actually go in there and look at that exact spot and say, this is it. I can see it. And they can also feel it and then see it again. And it really can be helpful. You really want to know, what do you see at that exact spot where this mass exists? And if they see the mass, then we usually let the radiologist determine if they think there would be a benefit of also getting a mammogram. Typically, we as primary care doctors don't order the initial mammogram, but the radiologist might think that there's something about the look where a mammogram might help them figure out the next step, which is typically biopsy. If it's a cystic mass, then you can often, they can just aspirate it and it will go away, and then we're done. If it's a solid mass or a complex mass, then it typically needs to be biopsied, and the radiologist will do a core needle biopsy, and then you have your answer. If I think the more challenging question is what we do when that ultrasound is negative. So if the ultrasound is negative, but there's still a mass, either the patient's convinced that there's a mass or I'm convinced that there's a mass, there's a couple things we can do. If the patient's young and otherwise totally healthy, you could have them go home for 2 months, come back in 2 months through two menstrual cycles, and many of these will resolve on their own. And if it goes away, then you're done. If it doesn't go away, or if they're not menstruating, then they should go to a surgeon for evaluation and consideration of a biopsy based on just the feel of it, even if you don't see it on ultrasound. The process is pretty similar for women over the age of 40, over the age of 30 or 30 and older. But in that case, you typically order the diagnostic mammogram as well as the ultrasound, and they get both studies because one may miss something that the other one might capture. And the performance characteristics of the mammography in women over the age of 30 is just better. And so it seems reasonable to do that.
Is there a case in which you would get just the mammogram as opposed to both? I
don't think so.
Women over 30?
Yeah, I don't think so. I think because 10 to 15% of breast cancers are not visualized on a mammogram, that the ultrasound can really help complement the mammogram. And this is, again, an ultrasound done for case finding. We know that ultrasounds alone are not good screening tests for breast cancer because there's huge numbers of false positives. But if you're looking in a specific area, then the ultrasound can be very helpful. And it also then, can help you tell, is this a fluid-filled cyst or is this actually a solid mass? Is
there any role for point-of-care ultrasound as an adjunct to the clinical breast examination, or has it been looked at?
So that's a great question. I'm not aware of it being looked at or used in the primary care setting, but I will say that in our breast center at the Brigham, the docs and the nurse practitioners in that clinic will often, particularly for women when we're worried about a breast abscess, they do point of care ultrasounds, and that can help guide management, particularly, again, for women where we're worried about breast abscesses.
I haven't seen that. I've been to a couple courses, Stuart. I haven't. This doesn't mean it doesn't exist, but that hasn't been one of the uses that they're advocating for internists. Like one of the, maybe because there's a lot of nuances to it, but
yeah. Well, not only that, but it'd be hard to get expertise with our patient population when we're really, for the most part, screening, not diagnosing.
Well, how should we wrap up this first case here? I think we have a pretty good idea now what to do for, what should be on a differential, what kind of questions to ask, and what would be the workup for a woman that's presenting with breast mass. Nora, is there any other parts to this case? Is there a happy ending for Miss Cantwell?
Well, I think kind of one interesting teaching point to ask about might be just this follow-up piece, just about how mammograms are actually scored and what those scoring numbers actually mean. So just kind of briefly, if you could describe, let's say she got a diagnostic mammogram that had a BI-RADS 3 reading. What does that mean, and what do we do about it?
Yeah, so the BI-RADS is basically just a way of standardizing reporting of mammography imaging. And the radiologists score everything along the BI-RADS scale, starting with BI-RADS 0, which means that they have insufficient data to actually characterize what they're seeing, and they need additional imaging. So that just means it's incomplete. Patients need to come back for additional imaging. There's BI-RADS 1, which is basically completely normal. BI-RADS 2, which is some changes but completely benign, and studies have shown that the risk of cancer in BI-RADS 1 or BI-RADS 2 is essentially 0. BI-RADS 3 is where there are some changes that are likely benign, but the radiologist isn't 100% sure about it, and so they recommend close follow-up at 6 months. Up to 2% of BI-RADS 3 rated mammograms could be cancer. So it's still very unlikely to be cancer, but it's really one of these things where we just want to watch it much more closely. BI-RADS 4 is a suspicious lesion, and a BI-RADS 5 is highly suspicious, and both BI-RADS 4 and 5 lead to biopsy. So these are the solid or complex masses that are very concerning. And the next step is a core needle biopsy for all of those.
So I was going to say there's a neurologist named Martin Samuel who talks about if a patient comes to your office with a headache, their number one concern is they have a brain tumor. And I feel like if a patient's coming to you with a breast mass, even if they're not expressing that concern, their number one concern is that this represents malignancy. So I wonder if you wouldn't mind just talking us through some of the epidemiology of breast cancer, sort of how common is it, and sort of where is there a population cutoff where we should be more concerned about it, and where does that fall?
Yeah. So, women are highly concerned about breast cancer. Breast cancer is the most common cancer diagnosed among women. We commonly hear the statistic 1 in 8 women will be diagnosed with breast cancer, or 12.5%. That's a lifetime statistic. So 1 in 8 in your lifetime if you live to age 85. But breast cancer, the strongest risk factor is age. So breast cancer is really a disease of aging. It's much more common in older women than younger women. That said, women in their late 20s and 30s can still get breast cancer. And often when they do, they can have very aggressive types of cancer. So it's something we never want to completely disregard. And so, I think reminding people of the likelihood, particularly in these young women, the likelihood that a breast mass is cancer is incredibly low, but not zero. We need to follow these things through until we have a comfortable resolution. And again, if they still feel a mass or we still feel a mass and the ultrasound is negative, they go to the surgeon because you just don't want to miss a cancer diagnosis. But we can be very reassuring in those populations because the risk is so low. Whereas in older women, we're much more worried and much more likely to find a cancer. That said, women are very worried about the likelihood of being diagnosed with breast cancer, but we do know that breast cancer is highly treatable, and the vast majority of people who are diagnosed with breast cancer are cured of it. And the risk of dying of breast cancer is actually quite low. It's about 1 in 36 women, or less than 3% of women, will die of breast cancer. And I think that's particularly compelling when we compare that with the risk of dying of lung cancer, which is 1 in 20 women, or the risk of dying of heart disease, which is 1 in 3. And, I think women are often much more worried about their risk of dying of breast cancer. And I often remind them of the things that they can do to lower their risk of dying of these other cancers, of lung cancer or, even heart disease. And it's always a good chance to even talk about what things women can do to lower their risk of all of these things. So, exercising regularly, avoiding obesity, avoiding excess alcohol, which is associated with breast cancer, are things that we can be reminding them whenever we're talking with them about their fear of breast cancer.
And when women get the BI-RADS diagnosis that's like a 3 and they need further or a 0 and they need further imaging or follow-up, typically in my experience, the breast imaging center handles that follow-up as a primary. You have to be a little bit aware just to prompt your patient, hey, did you get this followed up? But typically it's not us suggesting when the follow-up is, right?
That's right. That is typically recommended by the mammography centers. The mammography centers are regulated through the FDA, and there are very strict standards that they have to follow as far as communicating with patients. So by and large, they do take care of those things, including, when women need biopsies, they are the ones that schedule the biopsy, because these are all done in radiology now, the core needle biopsies. That said, when a woman has a normal mammogram, I don't bother to reach out to them because they get the letter from the mammography facility. But when a woman has a BI-RADS 0 or a BI-RADS 3, and certainly a 4 and 5, but even with a BI-RADS 3, I will typically reach out to them and say, by the way, I saw your mammogram report. I know they've already reached out to you, but you need extra images, or don't forget, you're going to need to come in 6 months. And because there are unfortunately lots of people that fall through the cracks who never get back. And the radiology facility should loop back to us and say, oh, by the way, I can't reach this woman. Can you help? But I feel like, the belt and suspenders approach can be helpful there.
I like it. One last thing before we leave this first case with Miss Cantwell. If she had just come with no lump but breast pain, and her main complaint was, I'm just having pain in maybe one breast or both breasts, as Paul was saying, when patients tell me that complaint, I get the sense they are worried that's a sign of a cancer. So how do you respond to that, like breast pain as a complaint? Is cancer on your differential?
Yeah, cancer is rarely associated with pain or the answer when someone's only complaint is pain. I will certainly take a thorough history, do a very thorough clinical breast exam. If I don't feel any kind of masses, I won't do anything else other than to make sure that they are up to date with any appropriate screening, and then talk with them about some of the other things that can cause breast pain, like menopause or dietary issues. And then, think through, is there anything that they can do? Often even just a better fitting bra can be really helpful to attenuate these symptoms.
Great. Nora, what's up next here?
Well, we've got another case with another friendly face, Miss Mammogram, Miss Graham, who is 46 as well. She is just establishing care with you in your outpatient clinic. She's never had any sort of breast complaint, doesn't have any currently, and she's never had a mammogram. And so this gets a little bit into the breast evaluation without a breast complaint. Could you tell us a little bit about what the current guidelines recommend in terms of mammogram?
Yeah. And, I think maybe even before I mention that, I'll just say briefly, some comments about screening in general. So what is the purpose of screening? When we're screening, we are trying to find disease, in this case, cancer or breast cancer, early before it would cause symptoms, but also at a time where we can intervene and make a difference and lower mortality, lower the likelihood that cancer would cause them to die. We also want to make sure that any screening test has a good benefit, this mortality reduction, but with very few false positives and false negatives and other harms like overdiagnosis, which we'll talk about later, which are problems that screening can do where we find disease that we don't need to find. So, and maybe I'll just even define it now. Overdiagnosis, which I think we all now recognize is the chief harm of many screening tests, is when we find a cancer or find disease that we never would have found in the absence of screening. And this is something that's hard for people to get their head around, that, there could be a cancer in your body that is never going to progress, might even regress, or if it does progress, it progresses so slowly that you're never going to feel the lump or have symptoms from it. And you will live the rest of your life and die of another cause, and you'll never have known you had it. But if we do the mammogram and we find it, we don't know if that's a cancer that wasn't going to cause problems or not. So we treat it like we treat all cancers. And in that case, we would be subjecting this patient to the harms of treatment when they're not actually realizing the benefits. And so as we learn more and more about cancer screening, breast cancer screening, and some other cancer screenings, I think we're much more aware that this is a problem that we need to be cognizant of. So looping back to, what's going on with the guidelines. Well, prior to 2009, we had a lot of consistency in national guidelines, at least in the United States, where the guidelines generally said all women age 40 and over should be screened every year with a mammogram. And that changed notably in 2009 when the U.S. Preventive Services Task Force updated their recommendations and said that we should start routine screening for women age 50, continue screening every other year or biennially until they're 74. And then they said, or 75. And then they said age 75 and over, we have insufficient evidence to recommend for or against mammography screening. And this recommendation caused a huge uproar because of this question of what about women in their 40s in particular? And, who are you to say that the benefits are being outweighed by the harms? At that time, the USPTF emphasized the risks of false positives where you have to come back for additional imaging, and the risk of unnecessary biopsies where you have a biopsy that doesn't lead to a diagnosis of cancer. And the response was, these are not that big of a deal. Yes, they might cause anxiety and mood changes, and there's some inconvenience of biopsies and maybe some pain and bleeding, but by and large, they're not that big of a deal. And, you're talking about maybe a life saved. Who are you to say what these benefits and harms are? And so I think that since then, a few things have happened. Number one, in 2015, the American Cancer Society, who had always just said, let's screen everybody frequently and, relatively early, they revamped their guideline policies, the development procedures, and they changed from recommending mammograms every year starting at age 40 to recommending mammograms starting at age 45. They said do them yearly until a woman's 55, and then do them every other year until the woman has a life expectancy of 10 years or less. And they said women age 40 to 44 should have the option to undergo annual mammograms, but recognize that the benefit to harm ratio in these younger women is less than it is for older women. In 2016, the USPTF reinforced their same recommendations from 2009. So again, recommending mammograms every other year starting at age 50 with individualized decisions before age 50. In the US, still, the American Radiology Society does recommend mammograms every year starting at age 40. So there is still some disagreement among organizations here. But in the rest of the world, we have been screening much more aggressively in comparison. So in most of Europe and Australia, recommendations have typically been every 2 years or every 3 years, starting at age 50 and usually going to age 70 or so. And there's even a couple years ago, the Swiss Medical Board created a lot of attention when they published an article saying, we've reviewed the mammography benefits and harms, and we think as far as screening programs go, we could use our scarce medical resources much more effectively in other things. And they actually decided they were not going to start any new mammogram screening programs and maybe even phase out their existing programs. So I think that this is sort of one of these things. These guideline bodies are sort of looking at the big picture population-based areas, saying, how do we think we can maximize the health of our population using scarce resources, and how does it make sense? And that has sort of led to this pulling back. But we'll talk a little bit more about, my approach and what I think we should be doing for women in their 40s and 50s a little bit.
Yeah, some of our listeners may be thinking, because there's a few studies that have come out that look at the impact of frequency of mammography and look at survival and really don't show a significant improvement based off of the increased frequency of mammography. And the largest study I can recall was, I believe in the Annals, it looked at 16 million Americans over from 1990 to about 2006 timeframe. And then when we look at the cancer survival, the 10-year cancer survival for breast cancer from about 1975 to 2010, it has improved by about 25 to 30%, give or take. One of the authors of an article that was published in the Journal of Cancer Policy in 2015 stated that this improvement in mortality was unlikely to be the result of advances in prevention or screening, but because of the improvement in the treatment of the cancer itself. How would you respond to someone who says that, well, maybe mammography itself is not for my patients, or the patients who say it's not for me?
Well, so those are all really great points. And, the data that we have on the benefits of mammography screening are limited. So there have been 8 or 9, depending on how you count them, large randomized clinical trials of mammography screening. However, they were conducted in the 1960s, 70s, 80s, and 90s. And so there is a lot that we don't know. And there's sort of two camps on this. There's one group of people that says, you know what? The mammography technology is so much better now that certainly the benefits of mammography screening would be better, because we can just see the cancers so much better with our digital technology. There's another side of the argument, though, that says, listen, in the 60s, 70s, and 80s, we didn't have great treatments for breast cancer. Treatment for breast cancer is so much better now that maybe there would be less of a benefit of mammography screening. And unfortunately, I'm not optimistic that we're going to have a great answer to that question. And we're sort of stuck with the data that we have. But I think that the benefits are smaller than most people recognize. And even when we think about what is the benefit, so if you do the meta-analyses of these randomized clinical trials, it suggests that the overall benefit of mammography screening is a 21% reduction in the likelihood of dying of breast cancer. That's not overall mortality. It's a breast cancer mortality endpoint. And and there's a couple things I'll say about that. So first of all, the 21% reduction in the likelihood of dying of breast cancer is great. It's certainly better than a 0% reduction. But what it also means is that of people who have cancers with the potential to be that are potentially deadly, still 79% of those women with these very aggressive cancers will die even if they have a mammogram, right? So we're decreasing a minority. The other thing is really important is that this benefit varies by age. So the risk reduction for women in their 40s is about 8%. The risk reduction for women in their 50s is about 14%, and it's about 33% for women in their 60s. So this is when we get back to what is the balance of the benefit and harms for women in their 40s, and part of the reason that the USPTF recommended against it. In fact, in the most recent meta-analysis, which was updated with the Canadian trial data, that was a null study for the benefit of mammography screening compared with clinical breast exam alone, there was no benefit. So in the most recent meta-analysis, this 8% risk reduction is not even statistically significant. I think it probably is real, but I also think it's probably very small. And so when we think about, these percentage reductions are relative risk reductions. If we think about absolute risk reductions, I like to talk to my patients and sort of frame this in a population of 10,000 women that I screen every year for 10 years. And over that 10-year period, for women in their 40s, we're likely to save about 3 deaths from breast cancer. For women in their 50s, it's about 10. And for women in their 60s, it's about 43. So even for women in their 50s and 60s, 10 out of 10,000, 43 out of 10,000, those numbers are still relatively small. And they're certainly very, very small for women in their 40s. And I think that this is part of the reason that we should be going away from routine reflexive, you're 50 years old, you need a mammogram, to you're over the age of 40, you need shared decision making about whether regular mammography screening is right for you. And we'll come back to talk a little bit more about how that conversation could go and what other resources are available to help us with that conversation.
So 3 in 10,000 for women in their 40s. I mean, it's like 99.99, percent at least are not benefiting from that. And I guess when you present it that way, and these are average risk women we're talking about, right? Because we do need to talk about how we're gonna, so for Miss Cantwell, Miss Graham. I'm sorry, I forgot we moved on.
We're on Mamie Graham now. Let's remember what we're talking about.
So for Miss
She's
Graham,
a little younger than her age might imply it.
Yes. For this 46-year-old, what do we have to make sure that what do we do to make sure she's average risk?
Right. So it's very important to be thinking about average risk versus high risk. And particularly when we think about high risk, we really want to be thinking about women who might have a genetic predisposition for cancer, because those women belong in a completely separate category and have, we start screening them earlier and we screen them differently, typically with both mammogram and breast MRI, because of their very high risk of cancer. And there is some evidence to support that more aggressive strategy. For younger women, we think about what are their risk factors, such as age. Again, one of the strongest risk factors, family history, hormonal risk factors like early onset of menarche, late menopause, late onset of childbearing or nulliparity. We also think about obesity for postmenopausal women. We think about alcohol use. We think about prior exposures like hormone replacement therapy, irradiation to the breast, are all key important things. And then, for women that don't have a lot of red flags, like I had radiation for lymphoma when I was younger, or I have a strong family history, then we typically turn to a risk prediction tool. The most common one out there is the breast cancer risk tool, which is on the NCI's website. It's based on a model called the Gale model that takes a lot of these risk factors, both age, exposures, prior breast biopsy was something I forgot to mention, and then gives you an estimated risk of breast cancer. It's worth noting that these models perform very well for populations of patients. They perform a little less well for an individual, predicting an actual individual's risk of developing cancer in the next 5 years, but they're currently the best thing we have. And so you can plug a patient's characteristics into the risk tool and it will give you a number that says, this 40-year-old woman has a 0.7% risk of breast cancer in the next 5 years. And then it will also give you the risk of an average 40-year-old woman, which is also 0.7%. And that gives you a sense that this woman's risk is average risk. If a woman's risk is substantially greater than average, then that might be someone where you want to talk about earlier or more regular screening. In someone that has a particularly low risk, then again, you might be a little bit less worried. And it is important to let them know that this isn't a perfect risk assessment, but that it does help them feel comfortable that you are not at particularly elevated risk of developing breast cancer. You're like the average woman. And so we can talk about breast cancer in that breast cancer screening in that context.
I was looking at the one tool, the BCSC. It was requiring that you know the patient's breast density. So wouldn't that require that they've already had a mammogram to know that?
Yes. And so let's talk a little bit about breast density. So breast density is a mammographic appearance description. So you don't know someone's breast density until you've seen a mammogram. And basically every mammogram is graded on a 4-level scale from almost entirely fatty, which is the least dense, to scattered fibroglandular tissues, which is the second category. The third category is heterogeneously dense. And then the fourth category is extremely dense. And we know that women with dense breasts have an elevated risk of breast cancer. And the other thing that's important to know about women with dense breasts is that there can be a masking effect where the breast density can obscure cancers. And so cancers can be missed. And it's a real challenge to try to figure out how to deal with breast density in our current population. There has been large advocacy in recent years, started initially by a PhD scientist named Nancy Capella, who was diagnosed with a stage 3B breast cancer just a couple of months after having had a normal mammogram. And she went to the doctor and said, how could I have had this normal mammogram? And the doctor said, well, you have dense breasts. And she's like, well, I didn't know that. And so she started an advocacy organization that has successfully led to breast density legislation in most states, and then most recently national legislation, and the FDA is now working on guidelines to implement a notification about breast density. And so these states now, and now nationally, there are laws that say we need to notify women about their breast density. The big challenge is that we don't actually yet have good studies to say, how should we do this notification? What kind of language should we use? Do women even understand what it means? And we also don't know what to do about it. What does it mean? Some of these notifications laws even require language such as talk to your doctor about whether additional imaging would be useful. But we don't yet know that the additional imaging is useful in preventing deaths from breast cancer. And we know that it could be associated with overdiagnosis. So it is really, really difficult to know what to do in this situation. There is some evidence that doing digital tomosynthesis or 3D mammography might be a little bit better for women who have dense breasts. You might also want to screen these women more often because the absolute benefit will be greater if your risk is higher, and these women do have a slightly higher risk. But it's still a little puzzling what to do about whether these women should undergo ultrasounds or MRIs, which are associated with more breast cancers identified, but also associated with a lot more false positives and possibly overdiagnosis. But back to the BCSC calculator, if you do know the breast density, that's another calculator that can be very helpful. I have done an exercise where, because one question that came to me once was, well, should I get a baseline mammogram? So I kind of have a sense of the baseline breast density. But in my experience in plugging numbers into the calculator, in a relatively low risk woman, there's not a level at which a high breast density is going to create a high enough risk that would make me want to change my recommendations. And similarly, in someone who's very high risk, even if they have low breast density, I'm not going to change my recommendations. So I don't find that calculator to necessarily be better, but it can be useful if you have breast density or if someone's really worried about their breast density to, help them to understand that I'm factoring in your breast density and you still are not at elevated risk of cancer.
That reminds me of the ASCVD risk calculator where, like, if they're young enough and they're a woman, like almost no matter what numbers you put in, like their risk is not going to go up.
Systolic blood pressure 220 doesn't matter.
Okay.
So you mentioned a couple of imaging modalities, which I always find a little bit confusing, and especially sort of patient selection for those. So you mentioned tomo, which I say like I know what it is, but I might not, and then also mammography, and then I will sometimes, very well done, Dr. Williams, but I will sometimes have patients ask for breast MRIs because mammograms are so notoriously uncomfortable. So I'm wondering if you just wouldn't mind sort of talking us through the different imaging modalities that are available and how you do patient selection for each of them.
Yeah. So, we'll start with just the standard 2D mammogram, which is now typically digital mammography. That is kind of the generally available everywhere and what we think is, the minimum, and the most standard thing. And then the question is, when would you use tomosynthesis or 3D mammograms? So 3D mammograms have the advantage of giving a little bit clearer of a picture. So it creates, it typically takes extra images and then creates this 3D picture that allows you to get behind certain areas that might obscure a mass. And this is really interesting. So there is some evidence that you can pick up maybe 1 to 3 additional cancers per 1,000 women with 3D mammograms or tomosynthesis. And the question of the increase in false positives or recalls, where women have to come back for additional imaging, is still a little bit uncertain, but becoming increasingly certain. So the initial studies suggested that it led to increases in recalls. And now what it seems to be is that in Europe, it tends to lead to increases in recalls where recall rates at baseline are pretty low. In the US, in our litigious society, where radiologists have traditionally been more conservative, our recall rates have historically been pretty high. And now there is pretty consistent data that suggests that tomosynthesis is associated with lower recall rates. But it takes longer for the radiologists to read them. So there's a staffing issue there. And it also is typically more radiation, maybe double the radiation of a 2D mammogram. It's still relatively low and below the limits it's felt to be unsafe. But it is a little bit more radiation, although newer technologies are moving towards allowing the recreation of these images without the extra radiation exposure. So I think we'll be there soon. And some institutions have just adopted tomosynthesis across the board. So at the Brigham, where Nora and I practice, if you go for a mammogram, you get tomosynthesis. That is less the case in smaller centers, but I think we're probably moving to there in the US, is my guess. So what about MRI? So MRI is a little bit more complicated. So MRIs also find more cancers per 1,000 women. But in this case, there tends to be a substantial increase in false positives. And the increase is such that in low to average risk women, the benefits does not seem to outweigh the downsides. But in high risk women, like women who have BRCA1 and 2 mutations, the benefits may be there. So we do recommend MRI in those populations. One of the other challenges with breast MRI is that these images are done with gadolinium enhancement. And there, is increasing evidence of gadolinium deposits in the brain after 4 or 5 MRIs. And so I'm still cautious until we know more about what that means. I'm a little reluctant to be pushing breast MRI.
That is terrifying.
For the listeners at home, because we're on a video call, the way that Matt's eyes widened and then he immediately started taking notes when he heard that was just...
Who knew they were with gadolinium, Paul? Did you know that?
No, I had no idea.
I had no idea. What do you need gadolinium for? Come on, radiology.
Makes to do it without contrast, but the current ones use contrast.
I'm shocked.
Yeah.
What about this strategy of mammography plus ultrasound for women with either dense breasts or just a higher risk women instead of getting like the MRI?
Yeah, and so in this case, it's what we're talking about is not the ultrasounds that we do to look for a breast mass in a woman with a breast mass, but it's what's called whole breast ultrasound, where you need to actually image the entirety of both breasts. And that tends to be time intensive, although there are automated whole breast ultrasound machines that are trying to improve on that technique. And again, we find a small number of increased breast cancers with ultrasound, whole breast ultrasound, but with a large number of increases in false positives and unnecessary biopsies and probably overdiagnosis. So this is where we don't have any long-term data to say that this is beneficial. And it clearly leads to downstream consequences of additional imaging, additional biopsies. And so it's really tough. I think for some women who are just really terrified about the risk of breast cancer and you try to explain to them what the downsides are and they understand that and they say, I still would rather know for sure, then it may be appropriate, but not without lots of work to help them understand that this is not a tried and true and tested screening test. This is an adjunct test that may or may not be of benefit in the long run.
What will and won't insurance cover when it comes to all of these?
So insurance is covering mammography for sure. And this is also very interesting. So this was one of the reasons that the USPTF recommendations were so controversial, because the Affordable Care Act, which expanded health insurance coverage, one of the other requirements was that it cover at no cost sharing any screening test considered at least a category, that was recommended by the USPSTF. And so people got worried that because the USPSTF was no longer recommending mammogram routinely for women in their 40s, that insurance companies might not cover it. Insurance companies have not gone there. It is covered with no cost sharing really for anyone over the age of 40, and then certainly for diagnostic purposes for anyone that it's ordered. The coverage of other tests varies by insurance. What has historically happened in institutions like ours that have expanded the use of tomosynthesis is that the radiation facility will put in the bill for tomosynthesis, and if it's covered, great. And if it's not, then they just take that bill back and submit a bill for a traditional mammogram, and that's always covered. So patients have not typically had to pay out of pocket for tomosynthesis. Breast ultrasound, whole breast ultrasound purely for screening is often not covered. And, for the infrequent patients who really insist on it, although, I think in some populations it's done much more often, it may or may not be covered. And we encourage them to ask their insurance company. Similarly, breast MRI for high risk patients, it's almost always covered. For low risk patients, they probably should call and check.
So bringing it back to our patient, Miss Graham, who's 46, and for these patients who are kind of between 40 and 49 without any breast complaints, how would you actually go about counseling her? Could you give us some of the language you use and the data to kind of to explain to her the risks and benefits?
Yeah. So, I'm a big proponent of shared decision making for screening decisions at all ages, but particularly for these women in their 40s, where I think that, we over the decades, we've led people to believe that the benefits of mammography are greater than they are. And so what I will start off with is I'll say, you're in your 40s. Current guidelines often recommend starting routine mammograms for women in their 50s and then individualizing decisions for women in their 40s. And I will say, it's important to know that mammograms are not perfect tests. We used to think, we used to message that everybody just needed their mammogram and made it seem that that's all you needed to do to prevent the likelihood of a bad outcome from breast cancer. But that we now realize was misleading. And so I say, mammograms are the best test we have right now, but they're still limited. And so then I'll walk through what are the benefits. So the benefits of mammography is that there is a small, particularly for women in their 40s, a very small decrease in the risk of dying of breast cancer. And I'll walk through the numbers. I'll say, if we screened 10,000 women in their 40s for 10 years, we would probably save the life for about 3 of them. Many women are still going to be diagnosed with breast cancer, and the vast majority of them will do well whether or not they had the mammogram. And then I'll say, there also are harms to mammograms. And I walk through the harms. I start off usually with false positives and unnecessary biopsies. False positives, when you get called back for additional images, are incredibly common. That same 10,000 women that we screen every year for 10 years, over 6,000 of them will have at least one false positive, at least one callback. So I tell people, it may not be that big of a deal, but just sort of expect it to happen. And when it does, don't say, oh no, I might have cancer. Say, my doctor told me this was just part of the test. Is sometimes you have to have 2 tests. The risk of unnecessary biopsies, when you have a biopsy that doesn't lead to a cancer diagnosis, about 7 to 9% of women, and of our 10,000 women, it's about 700 to 900 of them. And then there's this risk of overdiagnosis where we find a cancer that we never needed to know about because it would have regressed or not progressed. And that is, of those 10,000 women, it's about 28 that are overdiagnosed. And so then I say, I go through their risk and if they're average risk, these are the same numbers I use. Sorry, I should have said that first. I would always start with their risk. And then it's, the next step is eliciting their values and preferences. How does this feel to you? How do you feel about the, being potentially over-tested or over-treated versus how do you feel about getting breast cancer? Because, some women will be unlucky and will get breast cancer. How will you feel about it if you didn't have a mammogram, even if the likelihood that mammogram would have made a difference is incredibly small? And I have some women who say, oh yeah, I don't like all this excess testing. I'm going to wait till I'm 50, or, I definitely don't want to start now. And I have other women who say, I could never live with myself if I got diagnosed with breast cancer and hadn't had a mammogram. And so to me, that is the answer. That second woman, I say, well, let's start mammograms. And I'll often do them every year in those women, because I just think that this is important. So I think that there are increasing, so the challenge here is, how does the average primary care doctor do this, right? It's easy for me to do this because these numbers are in my head, because I think about this a lot. We can't expect the average primary care doctor to keep all these numbers in their head. And so what we really need are more and better decision tools where the doctor can say, go home and walk through this decision tool. Here it is online, or let me push it out to you on your electronic record patient portal. And I did write a brief clinical insight for JAMA about a year ago, where I included some links to some tools that are out there, and I can give those to you all to post as well. Because I think, and I actually have a printed copy of this in my office before I was doing everything in telemedicine, where I would hand it to the patient and say, we've had this conversation. If you want to learn more, here are some resources. And they're organized by women in their 40s or women age 50. And I just think that we need to rely on other people besides just the PCP to help women understand these benefits and harms, and to really think about, what does this mean to me? And I think that this even goes to women in their 50s, right? Like, I think that, as I mentioned before, our quality measures should not say what proportion of women age 50 to 70 had a mammogram in the last 2 years. They should say, what proportion of women over the age of 40 had a shared decision discussion about whether or not to have a mammogram. And I think there are a lot of women, even in their 50s, where they might say, you know what, I get that there's a benefit enough for the guidelines to recommend it, but I think 10 out of 10,000 is still pretty small, and I don't want to have it. And I think that can be perfectly appropriate as long as they understand the benefits and harms.
So you're saying that having my EHR just scream mammogram at me as soon as the patient turns 50 is maybe not the best approach, is what I'm hearing.
Right. And I actually think that, these guidelines have been interpreted to where many people are not having discussions for women in their 40s, which I think is also a mistake. And right. Interestingly, there was a first person narrative in Stat News, which is a local medical news journal, I guess, that where a woman said, who had been diagnosed with breast cancer, wrote this narrative, and she said, I was 43. I asked my doctor if I should have a mammogram, and my doctor said, if you don't want a mammogram, you don't need a mammogram. And then she was diagnosed with breast cancer, and she blames her doctor for her diagnosis. And she was clearly not making an informed decision about whether or not she should have a mammogram. And I think she should have been. I think that the doctor should have sat down and helped her understand the limited benefits of the mammogram, and then helped her engage in that decision about whether she should have a mammogram or not.
I think I've seen some of these tools. Usually they visually do it, where they maybe it'll show like a bunch of figures, and they're different colors. And they say like the green are the one who benefited, the yellow are the one who had harm, whatever. And they kind of visually show what we're saying. And maybe some of these resources you're going to share with us do that. But I think those kind of things, just even like, forget making it easier for the patients, it also makes it easier for the physicians who aren't like statistics experts to understand this and to explain it to people. It's like the blind leading the blind sometimes, Paul, with all these numbers. No,
I think anyone who knows our shows knows that we're an expert in statistics. But I mean, for other doctors, yeah, no, I can tell this might be a problem.
Yeah. Thank goodness for Rahul, if he's listening. Well, I think we should move on to our final case. So Miss Graham, I think, decided she'll wait till she's 50. She was average risk, and she didn't, she wanted to avoid extra testing. So Nora, what's the last case to bring it home?
So we have Miss Cantwell's mother here, Miss Britta Lumpworth. She's 75 and also new to your care. Sorry, guys.
Did Stuart
I went
write these
a little
names,
overboard with these names.
That's too
I don't
on.
get it.
Real deft touch. It's subtle.
That's
right?
too on the nose even for me.
So subtle. She has not gotten a mammogram ever. She has no complaints, is on a baby aspirin and amlodipine, and hasn't been to a doctor in 30 years. Should she be getting a screening mammogram if she's willing for some reason?
Yeah, so it's a great question. And I think that this question of when we should stop doing mammograms is a really good one. We don't have tons of guidance on this because there have been no randomized clinical trials conducted in women age 75 and older. All of our data come from observational studies. We know that older women have lower risk of false positives and unnecessary biopsies, probably because they have less dense breasts. But they also have higher risk of overdiagnosis because they have more competing illness. And so, our best estimates of the benefits and the harms are that of the 10,000 women in their 70s who get mammograms is that we would probably save about 20 lives. So better than women in their 40s and 50s, not as good as women in their 60s. So the more recent trend is based on some modeling studies that suggest that when women don't live at least 10 years, the likelihood of actually benefiting from the early diagnosis and treatment is relatively small. So current recommendations are leading towards saying, let's start phasing out mammography screening when life expectancy is less than 10 years, certainly if it's less than 5 years. And so in this case, what I would do is I would think about what's this woman's life expectancy. And we can either use life tables. I actually have a picture of life tables for men and women in the US that I have stuck on my wall in my office, and I'll pull it down and look at it with the patient. And in a 75-year-old woman, the median life expectancy is 12.6 years. And for a healthy, the top quartile, their life expectancy is going to be at least 17.6 years. And, Miss Lumpworth sounds to me like she's in that top quartile. So she's got probably 17 years or more that she's going to live. And I find it helpful even to share that with patients who often are surprised that, wow, I thought I was old. But, if you're old, if you make it to an age and you're still healthy, the likelihood you're going to live a lot longer is really high. And so in her, I would say, if anyone's going to benefit, it would be someone like you. Now, she's also done incredibly well for the last 30 years without seeing a doctor. And so I would be sure to make sure that she understands that going down this road could lead to a diagnosis, including an overdiagnosis of a cancer that would never cause her any problems. And the one caveat I should say about overdiagnosis is that, I've been using this estimate of about 19%, but that's, we don't really know yet what the precise number is for older women versus younger women. We think it's probably a little bit higher for older women, but our data just aren't great in that area. But, she might be overdiagnosed. But I think it's also important to tell women that if they don't get the mammogram, or even if their life expectancy is only 5 years and I recommend against it, it doesn't mean that they might not get diagnosed with breast cancer. The key is that finding that breast cancer earlier wouldn't have made a difference. And I think that it's really important that people understand that because, again, breast cancer is common in older women, and you don't want them to get diagnosed and have them say, my doctor said I didn't need the mammogram and I wouldn't get breast cancer. Like, that's not what I said. It's that finding it earlier wouldn't have made a difference.
And I know Miss Lumpworth, like I think I do. I think she's gonna shake your hand and walk out of your office with no mammogram.
And that might be the best thing for her. The one other plug I'll put out for is another life expectancy calculator called ePrognosis. This was developed by a group of geriatricians, and it takes not only age but comorbidity and health status and factors in and gives you an estimated life expectancy. And they even have an app that you can download that can help you think about screening decisions based on life expectancy.
As a just quick way to estimate, like for patients, a 75-year-old patient, I like to say, and tell me if you think this is wrong, I can stop doing this, but when you see a patient that's 75, but they're still like doing everything that they would want to, they're exercising, they look like they're in their 60s biologically, I would still screen those people as if they're in their 60s if they want to. And I usually say that to them. And it
Yep,
sounds like Miss
totally.
Lumpworth is in that category. She's like functionally a 65-year-old woman. And so maybe, like you said, she might benefit.
Right. If anyone's going to benefit, she will. But it would also be perfectly appropriate for her to say, I'd rather not. And, as long as, again, I've engaged her in a discussion with this where she understands the benefits and harms and she shares with me her preferences, then I'm comfortable with that.
Paul, this just won't stop coming up. Why can't everything just be black and white for us, Paul?
Tell me what to do.
Just tell me. Is there a procalcitonin? Does that help with breast cancer screening, Paul? Okay. I think we should probably get take-home points. Nancy, you've given us so much of your time. We are eternally grateful. This was very, very helpful for a discussion that many of us have several times a week. So take-home points, give us a couple favorite ones.
Yeah, I think my number one take-home point is that we really need to be engaging patients in these decisions. That, this screening is not black and white. The mammography test is just not as good as we've racked it up to be over the years. We really need better tests and better ability to distinguish overdiagnosed cases from cases that we really care about.
All right. Well, thank you so much. Did you have any plugs that you wanted to, any websites or anything like that you wanted to leave the audience with?
Yeah, if I can just maybe send you some things to post on your website, including some links to these shared decision-making tools, which I think are particularly useful for the busy clinician that just can't keep this in their head.
Sure. We will put those in the show summary on iTunes or Apple Podcasts. It is now as well. So people can click on those as they're listening to this. All right. Thank you. And have a good rest of your evening. Hopefully it's as exciting as this whole thing was with us.
Awesome. Thanks so much. It was really a pleasure.
Thanks so much.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
That's right, Nora, because we're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback, so please subscribe, rate, and review the show on Apple Podcasts or contact us at thecurbsiders@gmail.com. Special thanks to our producers for this specific episode, Nora Taranto, and to our social media team, Beth Garbatelli on Twitter, Maddie Mad Dog I'm not used to that one yet. Maddie Mad Dog Morgan on Instagram, and Chris the Chu Manchu on Facebook. Until next time, I've been Stuart Kent Brigham.
Claire, please keep all that in. And until next time, I've been Dr. Matthew Frank Watto.
I've been Dr. Nora Plout Taranto.
And I would be remiss if I did not thank the great Dr. Stuart Brigham for composing our theme music that you're hearing now. Also, special thanks to Claire Morgan of Notterly for editing our audio, which has to be just a Herculean task. And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.
And thanks to our partner, VCU Health Continuing Education, who's helping us offer free CE credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org for more information.